My name is AJ McCann. I'm an obstetrician gynecologist in Corvallis with Samaritan Health. I've been here for 16 years, going almost 17. I recommend skin to skin for my patients, and frankly, a lot of our patients already want skin to skin, just for the bonding benefit, for temperature regulation, to help with breastfeeding, and for maternal benefits of feeling close to their babies immediately after birth. You know, I don't do a lot of vaginal deliveries. I usually get called in for the more complicated ones, and in that situation, I think the barrier mostly is just fetal well-being. How's the baby doing right after birth? And initially, we would always whisk the baby off to the warmer for evaluation. And I feel like our pediatricians and our nursery staff are a lot more willing to do those initial assessments on mom now. And so some of those barriers have been broken down, even for a baby that may not be perfect at birth, that could be a vacuum or forceps delivery, or a delivery where we're a little more worried about the fetal heart rate tracing. And so that's been a great change, that we can do the initial assessment on mom while skin to skin is happening. And it's been a culture shift in the hospital. The patients and the nurses and every other staff, the pediatricians, have all been willing to do that shift. I think there's a lot of things that we do in the hospital just because we've always done it that way. And I think that's true for C-sections. I remember when I first started, we would deliver the baby would go to the warmer, maybe the nurse would show the baby to mom, and then dad and the baby would go to the nursery while we were finishing the C-section. Even in my last 16 years, that's changed. The baby stays in the room now, the baby goes to the mom and stays with mom if everyone's stable and routine. And that's been a great change. And you know, we've done rooming in, and so all of these things are modifiable. We just need to have a conversation about it and let everyone know that this is an okay practice to do. Mm-hmm. So when we started trying to implement skin to skin in the operating room, it's been a little bit of a culture shift, but it hasn't been difficult. The nursing staff and the pediatric staff were willing to make some changes that were not very difficult. We just needed to make everyone aware of why we were doing it and the benefits. It was important to include anesthesia in this also, because they're up by the mom's head and they're right there with the baby and the dad and everyone else. And they were all willing to make those accommodations. We were even able to get some drapes that we haven't used a ton, but that have a drop-down flap so mom can actually see some things. And there's even a drape that we played around with the pass-through, so we can hand baby through to mom. And start skin to skin. I've had many times where baby's not even gone to the warmer. If baby looks great, we do 1 minute of delayed cord clamping, and the pediatric nurse takes baby straight to mom, and we can start skin to skin right away. Certainly if baby needs to go to the warmer, then we do that, and if any resuscitation needs to happen, that can happen there. But again, even our pediatricians, even some of the more conservative pediatricians, are more okay with getting baby back to mom as soon as possible. And it has not been a difficult transition. I think education and just communication about it is the key. Yeah. Moms are so happy to get their babies to them right away. In any birth, that's what they're there for. They're there to get their hands on that kiddo that they've carried for 9 months. And so anything that we can do to make that happen faster is better. I hated the old days where babies were not with mom right away. Golly, in my residency, the babies went to the nursery and stayed in the nursery overnight, and moms never even had their babies. And so that progression has been so nice, because moms want to bond with their babies right away and have that immediate contact with them. Yeah, and like I said, even some of the more conservative pediatricians were okay with it. I mean, once we started doing it and they saw the benefits, there was no problem. I think if there'd been any negative outcomes or any concerns about that, then it wouldn't have gone as smoothly. But clearly this is a good thing for mom and baby and doesn't result in any negative outcomes, which is important. I think there are probably parts of the country that this will be a bigger transition. Like I said, in my residency, where babies would go to the nursery right away and stay there for hours, I suspect there are still parts of the country, that was in the South, in Texas, where that happened. And depending on the culture of the hospital, I think there are some bigger global shifts that would need to happen that would be more mother-baby friendly. And so this might seem like a giant undertaking for hospitals that have that current mentality. But it's a baby step process, you know, starting with getting babies rooming in with moms and doing couplet care. And then this is a very easy transition to do from there.